Hello friends, today we are going to discuss about brachial plexus. Now, how does brachial plexus form and what are its clinical correlates we are going to discuss later in this video. I'm going to show you step by step how it forms, and later on we are going to consider some of the clinical implications which are related to the brachial plexus. Let's go on. It is formed by 5 roots: C5, C6, C7, C8 and T1. As you see here, this is C5, C6, C7, C8 and T1. Now the brachial plexus can be majorly divided into 4 parts, which are the roots, trunks, divisions, and chords. Now what are roots, what are trunks, what are divisions and what are chords? Roots are the beginning stages of the brachial plexus, which means the cervical root and the first thoracic nerve root. Now these roots, these are going to combine to form what we call the trunks. Those trunks are going to give us the divisions, and those divisions are later on going to form the chords. How are the roots going to combine? You might say the C5 root, cervical fifth root, is going to combine with C6 root. The C7 root is going to continue as such. The C8 cervical root is going to combine with thoracic first root. This is the initial blueprint that we are going to follow for the brachial plexus. Now till here it was the roots. Now after this dotted line that you see I've drawn here, we have entered into the territory of trunks. Now this is the upper trunk, this is the middle trunk, and this is the lower trunk. Okay, the upper trunk formed by the combination of C5 and C6, the middle trunk formed as a continuation of C7, and the lower trunk formed as a combination of C8 and T1 nerve roots. Now we leave the territory of the trunks and enter the third territory, which is the territory of divisions. Now remember, each trunk, that is the upper, middle and the lower trunk, is going to divide into anterior and the posterior divisions. To make it easy, I am going to give you a mnemonic so that whenever you have to draw it in your undergraduate examinations, you know that mnemonic to draw it easily. That is AP, AP, PA. Now you might ask, what is AP, AP, PA? This is the anterior, posterior, anterior, posterior, and posterior, anterior. Okay? This is anterior, posterior, anterior, posterior, posterior, anterior. Now these AP and PA are actually the divisions in which the trunks have divided into. The upper trunk has divided into AP, that is the anterior division, posterior division, middle trunk into anterior posterior divisions, and the lower trunk into anterior and posterior divisions. Now I hope you are getting all of this. Now moving on to the last part, which is the chords. Now here the things get a bit complex, and here you have to be vigilant on what I'm going to draw here. The anterior chords, the anterior divisions of the, are you following me? The anterior divisions of the upper and the middle trunks, all right? The anterior divisions of the upper and the middle trunks, they are going to combine to give us what we call the lateral cord. Understand? The anterior divisions of the upper trunk and the anterior division of the middle trunk, they combine together and form the lateral cord. Now we move on to the posterior cord. The posterior cord is simply a combination of the posterior divisions of all the trunks, the upper, middle and the lower. I repeat my words. The posterior cord is actually a combination of the posterior divisions of all the three trunks that you see here, upper, middle and lower. Now let's continue. The posterior division of the upper, the posterior division of the middle and the posterior division of the lower trunk over here. They've combined to give us what we call the posterior cord. Now what we're left with? We are left with only the anterior division of the lower trunk, because the anterior divisions of the upper and the middle trunk had combined to give us the lateral cord. The posterior divisions of all the three major trunks had combined to give us the posterior cord, and only the anterior division of the lower cord is left, which continues as such to give us the medial cord. I hope you're all following me. C5, C6, they combined to give us upper trunk. C7 continued as such to form the middle trunk. C8 and T1 roots combined to give us the lower trunk. Now the anterior division of the upper and the middle trunk combined to give us the lateral cord. The posterior division of all the three trunks, they combined to give us the posterior cord, and the only left was the anterior division of the lower trunk, which continues as such to form the medial cord. Now as we've reached till here, we are now going to continue on the terminal nerves which emerge from these cords. Now you see here that this is the lateral cord and this is the medial cord. Simply join these two. As if they're closing on to each other. And over here we give this nerve, which forms from the combination of the lateral cord and the medial cord, the name median nerve. The nerve which is going to originate from here before the formation of the medial nerve is the MCN nerve, or the musculocutaneous nerve. The nerve which is going to form from the medial cord before formation of the medial nerve is the ulnar nerve. And just not to make things too confusing, the posterior cord, which had formed from the posterior divisions of all the three major trunks, divides into two nerves, which are the axillary nerve and the radial nerve. And just pause for a second here and just go through all this infrastructure and the thing I've drawn here and try to memorize this so that you're able to continue to draw this yourselves even. Alright, the lateral cord and the medial cord, they're going to combine to give us the median nerve. Before the formation of the median nerve from the lateral cord, we are going to get the musculocutaneous nerve, and before the formation of medial nerve from the combination of lateral and medial cord, we are going to get the ulnar nerve from the median cord. And the posterior cord, it is going to give us the axillary nerve and the radial nerve as its terminal branches. Now some small nerves, this is the major and the big chunk that I've drawn here for you guys. Now the small nerves, they arise as well. Some of them are important and have clinical implications, such as the long thoracic nerve. The long thoracic nerve is formed from the primary rami of the C5, C6 and the C7 nerves. And hence, as the name indicates, it is long, so being the long thoracic nerve. Now the roots, that is the 5C6, C8T1, these have a great clinical implication, as we will see later. And all these nerves that you see over here all have their root values according to this in the beginning that I've drawn here. Alright, for example, the musculocutaneous nerve, if I ask you what is the root value of the musculocutaneous nerve, you can say musculocutaneous nerve, if you trace it back, is formed from C5, C6 and C7. C5, C6 and C7, ultimately giving us the median musculocutaneous nerve before the formation of median nerve. So just like this, if you're asked to tell the root values of any nerve, you can just trace back your path and find out the root values. If you're asked to give us the root values of ulnar nerve, it is formed simply from, if you trace it back over here, C8 and T1. And median nerve, because it is formed as as an amalgamation of all the roots, so its root value is going to carry with it all the roots, that is C5, C6, C7, C8 and T1. So in scenarios which might be indicating median nerve injury and they asked what is the root value involved, then you are going to click the option to be C5, C6, C7, C8 and T1, all of it. Alright. Now I have gathered some scenarios which you might be interested in. Now the first scenario reads as such: a baby girl was delivered in the hospital by an obstetrician by pulling baby's head using forceps. 2 weeks later, the parents took the baby to the pediatrician for checkup. While examining the baby, the pediatrician found the baby's right arm to be medially rotated and adducted, while the forearm was extended and pronated. He also noticed sensory loss on the lateral aspect of the right upper limb. What is your diagnosis? Now, what do you guys think is the lesion? The lesion over here is the lesion of the upper trunk of the brachial plexus, which is formed by the roots of C5 and C6. Here you can see that this scenario correlates with the lesion to the roots over here, C5 and C6. Now, the damage to these roots is basically presented in a scenario saying that there was a baby who had undergone some type of forceps delivery or undergone some major difficult delivery, due to which there are two clinical signs that you have to look for if you're going to make a diagnosis of injury to the C5 and C6, which are that in the upper trunk lesion of the brachial plexus, the upper limb it simply hangs by the side and is medially rotated, and the forearm is pronated. We can also call it the waiter's tip hand, or the Herb Duchene's palsy, or the obstetrical palsy. In order to make the concept more clear, you might say, what does an obstetrical nerve palsy actually look like? The obstetrical nerve palsy, actually, I'm not so good at drawing, but still I'll try. Now you see, this is the arm which is adducted, medially rotated, and the forearm is pronated, just like a waiter is asking for the tip. Now we move on to the second lesion of the brachial plexus, which has a great clinical implication, which is the X paralysis. The X paralysis is caused by injury to the roots of C8 and T1. People always understand better with the help of a scenario, so without further going into the depth of X paralysis, we are going to read this scenario. A 50 years old construction worker, while working at a construction company site, lost his balance suddenly while standing at the edge of a plank on first floor. To save himself, the construction worker clutched the branch of a tree. He fell and sustained multiple injuries. A few weeks later, after the truncal injuries and bruises settled, patient noticed one deformity that did not go away. Upon examination in the hospital, there was wasting of hypothenar muscles, and the patient seemed to develop clawing of fingers. There is loss on examination. There is loss of biceps and supinator jerks, and there is cutaneous analgesia on a narrow zone along the medial border of the hand. Now this is a pure understood scenario for X paralysis. Now what is X paralysis? X paralysis, it results from injury to the C8 and the T1 nerve roots. Now when the C8 and the T1 nerve roots are injured, what had I told you before, that ulnar nerve, if you trace it back, has its origins in the C8 and the T1 nerve roots. Now the muscles and the area and the cutaneous sensations which are supplied by the ulnar nerves, they will be greatly affected by the damage to C8 and T1. So you can see here that on examination there was loss of biceps and supinator jerks, and cutaneous analgesia in a narrow border along the medial border of the hand, which are the areas supplied by the ulnar nerve. And moreover, in scenarios for X paralysis, they're going to give you a hint of extreme and sudden adduction. Over here, if we look at the scenario, to save himself, the construction worker clutched the branch of the tree. He fell and sustained multiple injuries. The patient clutched the branch of a tree, which indicates that there was sudden abduction. Alright, there was sudden abduction which led to the injury of the C8 and the T1 nerve roots, which led to X paralysis and the cutaneous analgesia along the areas which are supplied by the ulnar nerve. Alright. Now this is the main flow chart actually that you have to remember for all kinds of difficult and tricky scenarios. And similarly, the nerve which I have drawn here, as you can see, which is the C5, which is formed from the rami of C5, C6 and C7 nerves, which is the long thoracic nerve, and if this is damaged, this can lead to the winging of the scapula. So the major lesions I am writing for you over here, C5, C6 can lead to abductions, C8, T1 lesions lead to X paralysis, and C5, C6, C7 lead to winging of the scapula. Alright. Now, sometimes an MCQ is asked, what is a prefixed brachial plexus and what is a postfixed brachial plexus? A prefixed brachial plexus is a plexus which is formed due to more contribution from the C4 spinal nerve root and less contribution from the T1. And similarly, what is a postfixed, which receives more innervation from T2 and less innervation from C5. Simply, you can move this plexus one root up and one root down, making it a prefixed plexus and a postfixed plexus respectively. Alright, this is all for the brachial plexus. If you like this video and want to learn more about the proximal lesions versus the distal lesions of the different nerves, for example, the median nerve lesion, what will be its presentation if it's a proximal median nerve injury versus if it's a distal median nerve injury, and what will be the different presentation if the radial nerve is damaged proximally and if the radial nerve is damaged distally, and similarly if the ulnar nerve is damaged proximally and if the ulnar nerve is damaged distally. If you want to know all about that, just give this video a thumbs up and subscribe to my channel so that I can continue to make that video and you guys can solve all the difficult problems related to that easily. I hope you've understood the infrastructure of the brachial plexus, and I'll see you in the next video. Thanks.